Peptic ulcer disease. There are two types of peptic ulcer disease. We'll go back to the previous page under gastritis because the treatment for gastritis and peptic ulcer disease is similar, and they covered it under gastritis. And then here in this section, they'll just refer us back to gastritis. So the peptic ulcer can be gastric or duodenal, or even esophageal. But the two most common ones are gastric and duodenal ulcers. So together they're called peptic ulcers. So what is a peptic ulcer? It's an excavation or a hollowed out area of the mucosal wall. So what protects our GI tract from our own stomach acids? Because hydrochloric acid, for instance, can melt metal. Okay, it can clean. Who uses hydrochloric acid here to clean toilets back home? I know in the islands, right? So we have them. It's very effective, right? You will turn any, dark tile white, right? Yeah, and bleach it white. Okay, so that's hydrochloric acid. We have that in the stomach. How does that not melt our stomach? Okay, we have a mucosal barrier, right? So we have cells throughout the GI tract from your mouth all the way to your rectum that produce mucus, and that mucus protects us from our acid. So as long as those cells are intact, we have an intact mucosal lining, we're fine. Now, what happens if there's now an excavation? There's now spots, the hollowed out spots that do not have a mucosal barrier protection, because now there's an ulcer there. What will happen to those areas when exposed to acid? Number one, pain, yeah. Plus now the blood vessels are exposed, right? Because you have no more mucosal protection. So what happens? You pour acid into that. What will happen? Okay, so we'll mention some of the consequences, some of the complications of peptic ulcers. So we'll start with the risk factors, who gets it, what are the signs and symptoms for each, and then what will be the management, okay? And then patient teaching. Okay, so this is your stomach. There's an ulcer right there. Okay, so that's how it will look if you have a excavated area there. Let's look at the causes or risk factors. More men than women. Okay, so kind of equal, but higher in men, and increases with age. Most common causes are NSAIDs use, chronic NSAID use, and H. pylori infection. Between the two, the H. pylori is the most common cause. What is H. pylori? So this stands for a Helicobacter pylori infection. That's a bacterium. Okay. How do we pick it up? Possibly from contact, or let's say you violated the 5-minute rule. Okay, so you picked up something on the ground, ate it. So you pick up H. pylori at some point in your life. They lay dormant, not all of them, not all infections cause an ulcer, but those that do, because it's an infection, so do we treat it? Yes. Okay. So how do we know whether it's NSAID, caused by NSAID, or caused by H. pylori? Well, we need a biopsy. So once let's say we go for a CAT scan and we see the ulcer, then your doctor will order that endoscopy. So they'll put the scope down your throat and then get a tissue sample off of that ulcer. And if it's positive for H. pylori, then we'll treat the infection. If it's negative, then most likely caused by NSAID use, and it's on your profile. Let's say we learn, oh, you have arthritis, or let's say you have lupus, or some inflammatory chronic disorder that you take NSAIDs for. Okay, that's the case. In that case, we'll discuss how we can still allow the patient to continue taking NSAIDs while protecting the ulcer, okay, and then preventing future ulcers from forming. Any questions so far? All right. So I already mentioned Why would someone take NSAIDs? Well, they have no choice. Okay, they're in pain. So arthritis patients, osteoarthritis or rheumatoid arthritis patients, those guys are in pain. So they take NSAIDs, or any other condition, what they take NSAIDs for. Let's say they have gout. Okay, those people take NSAIDs. Okay. So how does NSAIDs cause ulcers? So what is the action of NSAIDs? They inhibit what? How do they decrease pain? They inhibit prostaglandin synthesis, correct? Now, what is the role of prostaglandin here? Prostaglandin is a vasodilator. It's useful in cells, tiny cells like the ones that are producing mucus in the GI tract. So they help those, and they also help the nephrons. Okay, so we need prostaglandin because it's not just a neurotransmitter for pain, it's also a microcellular vasodilator. So it's helping maintain circulation to the microscopic cells producing the mucus. They also helpful in maintaining patency in the nephrons. Okay, so no, how microscopic are the nephrons, right? So the prostaglandin plays a role in that. So therefore, if you take a drug and said like ibuprofen, aspirin, or Aleve, whatever, naproxen, what are ketorolac, okay? So all those NSAIDs therefore inhibit prostaglandin. So what happens to the nephrons? They get less blood flow, right? So they turn ischemic, they can die, they can, it can result in acute tubular necrosis. And then in the case of the gastric mucosa, what will happen to the cells producing them? They also receive poor circulation and they produce less mucus, so exposing your mucosa to the acid. Other causes are smoking and alcohol. However, here, as stated here, evidence is inconclusive, but they believe it plays a role as well. But can we advise patients who do have peptic ulcer to stop smoking and stop drinking also? Okay. All right, let's go to so I already explained how the ulcer develops depending on your risk factor. Let's say it's caused by NSAIDs. I described how the chronic use of NSAID can develop into an ulcer. And then obviously the H. pylori infection can cause the ulcer. Now, how do you describe H. pylori? Imagine being in your GI tract. Let's say I turn you into Ant-Man, Miss Bromwell. Okay, so I miniaturize you, inject you into the mouth. Okay, and then you live in the GI tract. You're in the stomach. Describe that environment there. And what else? Okay, is it slightly acidic or very acidic? Okay, so describe an organism that lives in that environment. Can you say that's a puny organism or a hard-ass organism? A hard-ass, right? Imagine they can survive that environment, right? You put some tacos and hot sauce into, what else do you put in your stomach, right? And then all that acid, you drink alcohol. So it's a very hostile environment, but yet the H. pylori organism thrives there, right? So of course, in order to protect itself, what do you think the bacterium will do? Will it just lay there like this? Or is it gonna hide somewhere? It's gonna burrow a hole into the mucosa, and that's how they create the ulcer. Make sense? All right. So to protect themselves, of course, they're having kids, right? They have little kids, yeah. They're multiplying. Okay, hey, my kids hide here. Okay, so they burrow the hole, excavate the ulcer, and then you hide there. Okay, so that's where they live. Signs and symptoms now. So all that story there, it still leads to ulcer. Okay, let's go just to the short story. All right, manifestations. So how do we know the ulcer is in the stomach or in the duodenum? The main feature is in the pain. When does the pain start? So let's review our physiology. So when we eat, say you ate a burger, What happens to that burger when after you chew it and then you swallow it? Does it go directly to the duodenum?
No.
What does it do?
The stomach.
How long does it stay there? How long does it stay there? 72 hours. You eat every 72 hours?
No, 15 minutes. Depending on how much you eat. 2 minutes.
Yeah, I ate, so no, let's do physiology, not what you think. So it sits there for 1 to 2 hours, right? So anywhere between a minimum of 1 hour, could be 1.5, it could be 2 hours. Okay, so it sits there. What's it doing? Why is it sitting there? Okay, the burger is being turned into liquid, right? Yeah, so it's becoming liquid now. Even if you swallow the burger whole, it will sit in your stomach. Trust me, it will turn to liquid. When we put pepsin, gastrin, and hydrochloric acid there, it will turn to liquid. So once liquid, now it will proceed to so the pyloric sphincter will open and it will enter the duodenum in liquid form already. Okay, so the stomach, it sits in the stomach to liquefy it and then pass it on to the duodenum. And then since it's already liquid there, can it be absorbed now?
Yeah.
Yes, it'd be absorbed in your small bowels and then all the nutrients, the sugar is absorbed and next meal comes, we repeat the process, all right? Okay. So, does it make sense that you know the physiology? So this is how patients describe the pain. Dull, gnawing pain, burning sensation in the mid-epigastrium all the way to the back. The pain occurs when? The pain associated with a gastric or a stomach ulcer occurs when? Immediately after eating. Why? Why does the pain start right after eating? So what happens when you eat, when you're eating and then you swallow the burger? So you have an ulcer in the stomach.
So now the acids are moving.
Okay, it's stimulated, right? So the moment you start chewing, acid production begins in the stomach. So the moment you swallow, the liquefaction of the food begins. So therefore, of course, the ulcer is there. So is it exposed to acid?
Yes.
Yes, and then the patient feels this, but they continue eating it. Okay. Whereas the pain in duodenal ulcers occurs 2 to 3 hours after a meal. Why?
Take 1 to 2 hours.
Okay, it didn't get there yet, right? The acid didn't get to the duodenum yet until 2 to 3 hours later after the stomach already passed it on to the duodenum. Make sense? All right, so that's how we tell based on the characteristics of the pain. What is the pain pattern? So when the patient tells you, okay, oh, that sounds like a gastric or that sounds like duodenal, right? Approximately 50 to 80% of duodenal ulcers wake up at night with pain, whereas a small section patient with gastric ulcers, so more patients with duodenal ulcers have the pain at bedtime. Okay, and then some gastric ulcers have it, but lesser percentage. Other symptoms that accompany besides the gnawing pain, how else was it described? Dull, gnawing, burning pain. Aside from that, the patient also has what other symptoms? So signs of dyspepsia. Okay, so the patient has vomiting, constipation or diarrhea, and then bleeding, of course. Bleeding, that means, do we have bleeding ulcer now? Yep. Could be vomiting. Then we'll look at the complications. So complications are, of course, we have perforation, and then there's pyloric obstruction, then there's peritonitis. So once you have a hole in the stomach or in the duodenal ulcer, then we're dealing with peritonitis already. But we'll get to that later. So bleeding can be upper or lower, correct? So if it's gastric ulcer, of course, that will be upper GI bleeding. If it's duodenal, that will be lower GI bleeding. So here are a few of the symptoms, but we have a table for the complications. So this will be discussed in more detail in that table. Right. Okay. So I mentioned if it's H. pylori, we can only make that diagnosis with a endoscopy, right? And then we get a biopsy, and then we find out it's H. pylori. We'll get to the treatment shortly. Here, if it's H. pylori, it's a bacterium. So therefore, how is it treated? Antibiotics. However, what is this organism like? Is this a weakly? So is this a weakling or is this like a strong antibiotic? I mean, a strong bacterium. This one's pretty tough. So how many antibiotics do you think can this be treated with just one?
No.
Considering, this is a tough mofo? No, you'll need multiple, right? And then we will get to the treatment next. So here are the combinations. So 2 antibiotics minimum is required. Sometimes they'll do 3, but most common is 2 antibiotics and proton pump inhibitor, and then a few other drugs, symptomatic management. So recommended combination are 2 weeks, 10 to 14 days of triple therapy. If it's triple, then that means 2 antibiotics and 1 PPI. So combinations are metronidazole, which is Flagyl, and amoxicillin and clarithromycin. So that's one combination. So Flagyl or penicillin and clarithromycin. So that's 2, right? And then the PPI, either lansoprazole, omeprazole, or rabeprazole. All right. And then there's the quadruple therapy. They can do 2 antibiotics and a PPI and then a bismuth salt. A bismuth salt is like Pepto-Bismol. If the patient can't tolerate the PPI, then we'll use H2 receptor blockers. Okay, can be used. Of course, for symptomatic treatment, we'll use either one, H2 receptor blockers. Like, give me examples of H2 receptor blockers. These drugs end in what? Tidine. Okay, so ranitidine, famotidine, right? No, there's no more ranitidine. Ranitidine was eliminated by California, right? So we have famotidine, cimetidine. No more ranitidine available in the market. We have this table. Okay, so here are your tidines: nizatidine, famotidine, cimetidine. That's the therapy, 6 to 8 weeks. And here's PPI, any of these. So this is OR, okay? Because they really have the same action anyway. H2 receptor blocker and PPI have the same effect. They just do it differently, but both will reduce acid secretion in 2 different ways. Here's the antibiotics. All right, if the patient has to take NSAIDs, remember, some patients have no choice. Like if you tell them, okay, don't take NSAIDs, well, what do I about my pain? So they have to take it. So to protect the acid, they'll be given misoprostol. You heard this on the news, right? Last year, after Roe v. Wade it became famous. This is the drug used, one of the drugs used to for abortion. Okay, so that's I mean, that wasn't designed that way. It just happens to do abortion. So the really the purpose of the drug was to this is a prostaglandin analog. Remember, NSAIDs will inhibit prostaglandin. So this one will replenish prostaglandin. Okay, so therefore it kind of balances out. So this will help maintain prostaglandin levels. And a side effect, of course, causes abortion. So if a patient is pregnant or plans to, they cannot take that drug. Okay. And for the other drugs, I'll go back, like I said, I'll go back to gastritis. because we're also giving antacids. So let's go to the medical management of gastritis right here. So here are the antibiotics used. So for both gastritis and peptic ulcer, of course, for H. pylori, always two, right? Always two combinations. So amongst here are the drugs, and here are the testable part. So I'll ask you about the side effects, which are under your nursing considerations, meaning these are what you teach the patient. Any questions? You're on your own here. So this is a lot of reading. Like I'll ask, for instance, which one would, or what will you teach the patient taking tetracycline? So causes photosensitivity. So you tell them to use sunscreen and then avoid dairy products. Right? Plus, they're not on it for forever anyway. It's a 14-day treatment, right? 2-week therapy. So after that, they're okay with dairy and sun exposure. One drug that is going to coat the ulcer is in the bottom here. These are PPIs, you already know them. Here's misoprostol. Here, sucralfate. Now, this drug is a mucosal barrier fortifier. What it does is it coats the ulcer. So when you swallow it, it will form a coating, a white coating over the ulcer. So when should the patient take this? Oh, very good. So here, 1 hour before meals. What about at bedtime? Because remember, the patient may have acids during the nighttime, correct? So 2 hours here. So 1 hour before meals, or if the patient has other drugs to take, so 2 hours before, because remember, this is just one of the drugs. They're taking the antibiotics, the antacids, and the misoprostol. Okay, so the patient is taking multiple drugs. So make sure you time it correctly, right? And with antacids, what's the general rule for antacids? When should you take antacids? It's not really for meals. It's the... Yeah, you can't take it with other drugs because what will happen if you take an antacid with any other medication? You can't absorb those drugs. Okay, so that's a general rule. So there's timing is important here. So teaching is important, especially with the antacid. You must take it separately. Okay, so you take, let's say if you plan to take the other drugs at 8, make sure you take the antacid when? 7 or 9. Okay, because there's really no rule as to when you take an antacid, whether it's before or after eating. Okay, it's either or. Okay, so bedtime dose for sucralfate is also prescribed. Bedtime, that's what, 9, 10 o'clock. Okay. But definitely before each meal. So how long before each meal? 1 hour before each meal. That way it works. You need it to coat the ulcer first before you eat, because once you eat, acid starts producing. Okay, let's go back here. We're done with the drugs there. All right, let's finish our ulcer. We're in the, so that's pharmacologic therapy. Let's go now to the complications. I already mentioned this, right? About misoprostol? Yeah. Okay. We mentioned this also earlier, so stop smoking and either eliminate alcohol altogether or avoid alcohol. For diet, as you can see here, nothing really, there's no nutritional therapy to heal the ulcer, but we can avoid aggravation and improve symptoms by avoiding certain foods. Let's put it that way. Make sense? Meaning there's no nutrition therapy to treat ulcer, meaning there's no foods that you need to eat to help heal the ulcer, nothing like that, because all food will stimulate acid. So here, this is more for avoiding the symptoms. All right, minimizing the symptoms. So what are the avoidance, the foods that should be avoided? Okay, first is the extremes of temperature, not too cold, not too hot. Okay, alcohol, coffee, including the decaf. Whatever is mentioned. There, not really. So this one I mean by there's really no, let's put it this way. If a certain food causes you symptoms, what will you do? Then don't eat that. All right. So here it'll be like trial and error for the patient. Okay, so here the patient eats foods that are tolerated and avoid those that cause pain. Okay? Because there's really no rule. So it depends on each patient. That's what you teach them. So just try. Okay, but definitely what ones are we know to avoid? Alcohol, coffee, including decaf, and smoking too, right? If it comes to this, let's say the patient does have bowel perforation and the perforation is serious enough, then they'll cut a piece or a section of the bowel, depending on how long of the bowel they removed, will determine whether or not the patient will have an ostomy, right? You discussed ostomies in MedSurg 1, right? So if it's just a small section that was cut, you can still stretch the bowel, then no ostomy. But if it's a long section, I mean, how, right? And then you'll end up with an ostomy. I won't test these surgical procedures. That's not a nursing concern. That's for the providers. And for pre and post-op again, we already discussed post-op care before the break. And for pre-op, basically the preparation is NPO, right? NPO. If it's a lower surgery, of course, that will include bowel prep. Okay, you give them laxatives and the Go Lightly or enemas. But if it's upper GI surgery, then you just do NPO. All right, time for the complications now. Let's go to the most important is bleeding. I won't discuss the hemorrhage part because we did the hemorrhagic shock already, and then you took care of Mr. Lloyd Bennett. Let's look at the drug therapy now, because where is the bleeding here? In the exposed part, right? So the ulcer has now exposed blood vessels, arteries and veins, right? And then the acid caused it to bleed, right? They pour acid into the blood vessels, of course they will bleed. So what drugs are given to slow down the bleeding? It's pretty simple. You put them on a continuous drip of proton pump inhibitor. Because what's causing the bleeding? The acid. So therefore, it makes sense, right? That if you cut the acid down, then that will slow down the bleeding. So it's not just the, did you really go for the, which you did, you went for the blood transfusion, right? But what should be the first one to be given? Patients actively bleeding?
Yeah.
In normal saline first. So maintain blood pressure first, give the saline, and then hang the blood, and then the PPI. So the PPI will be later when the patient is more stable, then we can give the PPI maybe twice a day, every 12 hours, IV push. But if they're actively bleeding, it will be continuous. Okay, slow, continuous. The 40 milligrams will be given over 4 hours instead of over 2 minutes. All right, so that's how we handle GI bleed. And this is not just for peptic ulcer. Any GI bleed, are we clear? Any GI bleed, they'll be on a PPI drip. Are we clear? What's the purpose of giving PPI again? Okay, so if you read the technical rationale, it will say to prevent rebleeding. Because does the body stop bleeding on its own? Can we stop bleeding on our own? Yes, we can. You cut yourself, how does that stop? Yes, we can stop the bleeding, but once the body forms a blood clot over the vessel, if you expose that to acid, what will happen? It will rebleed again. So therefore, what's the technical rationale for using PPI? To prevent rebleeding, because the body will naturally perform hemostasis. Okay, so if that bleeding, if that artery, those capillaries are bleeding, we will stop it. Okay, the body will form blood clots, right? So we'll have platelets sticking there, no, and then clotting factors will, well, eventually form the, clotting cascade will eventually form clots and then plug that. Of course, unless it's a really huge artery involved, then we need to manually, surgically stop the bleeding. But if it's just a spontaneous, small arterioles or capillaries, our body will stop the bleeding eventually. We just need to prevent it from rebleeding. And what's the only way to do that? PPIs, right? So PPIs are our best friends whenever we have GI bleed patients, all right? So anticipate that. GI bleed, look for a PPI. Okay, tell the doctor, hey, active GI bleed. Well, how come I don't have PPI? Okay, so again, if it's actively bleeding, a drip, okay, continuous IV infusion of the PPI. What if it's stable now? Okay, twice a day IV push. So the Protonix, pantoprazole will be given 40 twice a day, every 12 hours, IV. Then once, discharged, let just be by mouth, obviously. So then take the PPI capsule. So this is what I mean. Many times the bleeding will stop spontaneously. However, the incidence of recurrent bleeding is high. So how do we prevent that rebleeding? PPI therapy. Very good, children. And of course, watch for signs of bleeding. So overt signs will be what? How do you know they're bleeding? Like, what's your physical evidence? The blood, okay? The blood that comes out, either they vomit it or in the feces, right? So what will be the color of the feces if it's upper GI bleeding? Black. What if it's lower GI? Dark or bright red. Okay, very good, children. So if we can't stop the bleeding through PPI, then obviously we need surgical intervention, either through endoscopy or open abdominal surgery, depending on where the bleed is. The bleeding cause in liver cirrhosis will be discussed separately because that's really a different cause. So we'll discuss that still under GI, but that's under liver. That's the last topic for the semester, for the program, actually. Yeah, for the nursing program. Okay, here are the other complications. So we discussed GI bleed. Now here comes the perforation and penetration. The questions on the exam will be, of course, the signs and symptoms and what your nursing actions are. So read each one. So how do you know there's perforation? Perforation will be similar to peritonitis because what will come out once there's a hole in the stomach or the duodenum? Feces will come out, right? Yeah, and there's bacteria there. So of course, will it cause peritonitis? Yes, basically, so when you say perforation, there's really peritonitis. So symptoms will be the same. And how do we know that? Here, sudden, severe upper abdominal pain. Radiates to the shoulders, right shoulder, vomiting, collapse, a rigid, board-like abdomen. As far as where the rigidity will be, it may start at the local area first. So let's say it's duodenal, so it'll be here. So the rigidity and tenderness will be here, but then it'll spread. So as the more feces, fecal matter come out, then it will involve the entire peritoneum now. Make sense? Okay. Gastric outlet obstruction. So here's another. So obviously this will be for gastric ulcer. So this one will be for the perforation. Can be both gastric and duodenal, but this one obviously is for a gastric ulcer. Manifestations are nausea, vomiting, constipation, epigastric fullness, anorexia, and weight loss. All right. That's it for